So just a couple days ago, I walked into this flower shop and I saw these two women behind the cash register, and they were putting together these bouquets. And it was these long lupins and blue hyacinths and the smell. And one woman put in these yellow daffodils and wrapped it up with this pink tissue paper and tied it with a red ribbon. And I thought to myself, I want that job. How many of you feel like that right now? So, I think what happens to us is in September, we've had the summer and we've been outside, we don't have the pressure of our job. We come in and we have all these great ideas and we're ready to take on our students, our patients. And then as the months progress, our energy dips. There might have been a major snowstorm and our patients, they're struggling. So maybe in September they were, maybe you had a school-avoidant kid who was missing 3 days of school in September. But then by January, they're missing in action and they're missing 3 weeks of valuable school time. Or you have a student who was smoking dope and now, they were smoking occasionally and now they're smoking every day and really disinterested and getting more depressed. Or there's a child with autism who has a learning disorder and as the months go on is getting more frustrated with trying to connect with other kids and is bolting from the classroom. So today, what I want us to think about is how do we build endurance? How do we build stamina? Stamina so we have the resilience to provide a connection to our students, our patients, and sustain hope. And what I'm going to be covering today is how to think about phantom patients, those kids that may be missing in action, how to think about chaos theory and how that applies to our work with students, how to think about creativity and humor, and then I'm going to end with two offerings that come from my patients in thinking about resiliency, because ultimately I think our patients are our best teachers. So let's say that you refer, you get one of these patients that I just talked about, and you're all set to go. Maybe it's September, maybe it's January, and it's a no-show. And it's another no-show. So one of the things I want to talk about is what's a paradigm that you can have so that when that phantom patient isn't showing, that you can keep yourself going. And one of the things that I think is so important is for us to think about how change can sometimes seem like it's glacial. And that if we have a paradigm, the paradigm that's often presented in our clinical setting, where 3 strikes, you're out, that's a setup for us feeling demoralized. Half of the high-risk patients that I've taken care of over 23 years would never fit under that criteria. It's an unrealistic timeline. And sometimes it can take, I like to think of it as like the mother-baby bond where you're trying to work towards secure attachment. And sometimes it can take up to 18 months to get a patient engaged. And I think of the concept of motivational interviewing, where you think about pre-contemplation, and that many times our patients come to us in a place where they're not yet ready to change. And there's a huge process of getting buy-in. And, just one small tip that I do is I do a lot of poking. And I've had patients come back many years later, and that kind of persistence where there's a balance, it's learned optimism and it's also outreach, makes a difference to our patients. And I'll poke by sending a text message. And I know, sometimes people will say that's not HIPAA, compliant, but a text message just to say, I'm here, I'm waiting, it's time, and it works. So the next thing that I want to talk with you all about is the chaos theory. You know, chaos is about things that are unpredictable, surprised, a trajectory that's nonlinear. And, you know, it would be nice if our patients followed a linear pathway where, you know, you showed them what needed to happen and they just gravitated to that. But our children often are different. And that's why they came to us, because they have had chaotic things happen in their life. Like they may have had woken, you know, an 8-year-old child who may have woken up with her mother overdosed. Or there may be a huge divorce that's happening and the teenager is a human time bomb between the parents. Or a young child is at home and the parents are hitting each other and screaming each other, and we are asked to hold this, to hold the kind of chaotic lives that our kids are living and provide scaffolding. And we have to have strategies to manage this, because it's the kind of thing that wears us down. If you have and many of us have had this, a teenager that comes into you and talks about being suicidal. Maybe it's a child who's been, a teenager who's been heading to a balcony and thinking about jumping off. And they come in and they confide that to you. And maybe you do an assessment and you decide, you know what, they're okay to leave. But then they become like the phantom patient and they don't return the next day. Or it's a patient who is talking with you about going back with their ex-boyfriend who has been really abusive to them, and they're going to go to a party and they're trying to decide whether they're going to hook up again with this ex-boyfriend, and then they don't come to the next session. And you are left wondering, is that because they ended up going home and they got raped and you haven't heard about it yet? And these are the kinds of things that wake us up in the middle of the night in January, where you may bolt out of bed and wonder, did I make the right clinical decision for these high-risk patients where their trajectory is chaotic, it's random. They may be lucky enough that they meet a therapist that they feel really connected to and they turn their lives around, or they have a drama theater that they love and they become this great actress and they tap into resources, or they make one of these scary outcomes that worries us because we care about them. So I just want to share a couple quick thoughts about this. One is something that comes from Tom Gutile, who's a forensic psychiatrist, which is, if you don't write it down, it doesn't happen. And that seems really obvious, but I want to share with me from, having done safety assessments with high-risk kids who often have intimidated educators or diagnostically complex kids, and supervised for over 23 years these kinds of assessments, is oftentimes when we're stressed, we may not write down the process of making our decision. And that's the key part. And write it down on the medical record, write it down on a Word document if you're an educator. But there's two things that this does. One is, God forbid if there's a bad outcome, you have shared why you thought it was safe, say, to let that boy leave when he had shared with you that he had some suicidal ideation. And that the other part is that in writing a narrative, you're imposing order on chaos. And that also helps. Another tip that I would say, which is fairly obvious, but I'm still going to share it, which is to Each one of us should have a trusted colleague that we reach out to when we're struggling. And sometimes what happens is that we feel vulnerable, so we barricade ourselves and we think we should know the answer to this, or gosh, I'm a seasoned clinician, I ought to be able to manage this. And I would really encourage, I have actually 5 people on speed dial because sometimes they may not answer. And I will call, and sometimes when I'm really struggling, I'll do it while the patient and the family are in the room, because I want to reassure them that there may be algorithms, but there's still a process of judgment, and that I'm sharing the responsibility both with them sometimes and with the clinician in thinking about the decision. And it may be something like, you have an irritable child, and for me it might be something like, I'm trying to figure out, do I start an antidepressant because is this major depression, and or is it ADHD that hasn't been medicated properly and that's why they're looking irritable, or is it a good idea to give no medication and to watch and to get more information? And I find that having trusted colleagues provides a resiliency for me that keeps me in the game, particularly when I'm struggling with the most difficult patients. So the other aspect that I think is really important is learning from our mistakes, or being able to think about our setbacks. And, Mary Oliver, she's a Pulitzer Prize winner, and, she cuts to the chase. It's probably why she won the Pulitzer Prize, but she says, you want to cry out loud when you make a mistake. And tell the truth, the world doesn't need any more of that sound. So, what does that mean? To me, it means sometimes when we have a mistake, we beat ourselves up, and it's a waste of time. And what we really want to do is to figure out a constructive way to work with our setback. And each of us wants to have a strategy to do combat. And I find that there's a book that I really enjoyed. It's called Don't Shoot the Dog. And it's written by Karen Pryor. And she was someone who worked with animals, dolphins, dogs. And the concepts that she used extrapolated to people, and so she's ended up working with people. And I wanted to share one that I think is particularly relevant with thinking about setbacks. And some of you may have heard it being called an extinction burst, but it's about the learning dip. And what it means is that sometimes we have this unrealistic expectation of ourselves, that our learning is linear, and we just move forward, and there's never a mistake, never a setback. And that's a setup for us. Because really, if you think about learning dip as that it's a detour, that's an expected detour, not always feeling like an expected detour, before you have insight, before you have progress. And one of the questions we want to ask ourselves is, why sometimes do we get stuck where we don't progress in our learning? And I think it's because when we have a detour, we have a cognitive framework that begins to catastrophize or to magnify the mistake, and we get frozen in that place. So that we want to have explicit strategies for how we mobilize when we get into that detour. So I asked a accomplished writer. Some of you may know that I have a passion for writing, and I wanted to know, and this is applicable to our most difficult patients, what do you do when you get stuck? What do you do when you get to that point in a draft and you're like, this is just word jumble, and you just start to bring out your, hammer and beat yourself up. And he had a straightforward, but I thought useful idea, which he said, he takes the introductory page, the first page, the final page of the final project, which is polished, looks great, and he places it on his office wall. And then he puts next to it his first draft that he wrote. And the distance between it is so reassuring to him that there is expected detours and that there's going to be a time when it feels like there's nothing there to share, and then it allows them to move forward. And I think that's true with us, that to me, in my most difficult cases, and I unfortunately have a reputation for working with difficult kids, there's a point in the treatment or in when I'm negotiating with teachers where I feel like there is nothing that's going to work. And holding on to that history you have of having seen progress, really allows us to keep our stamina. And I want to share something, again, I don't mean to sound patronizing, but this is something that a supervisor shared with me 23 years ago that I found was helpful. And I would encourage us all to find a strategy. It doesn't have to be these that I'm sharing. But she had said, one thing that can help when you're feeling destitute is to have a file. So in my office, I have a file that's called Positive Accomplishments, Positive Reinforcements. And I tuck into it all sorts of random things. So I may get, not that it's random to get a compliment from a patient, but I might put something where a patient has sent me some good news about the progress they're making, or a compliment from a peer about something that I've done, or a thank you note from a teacher when I was a mother's helper doing something like sifting sand. And this folder isn't huge after 23 years, I wish it was, but it's big enough that on those days when I'm really questioning my ability to make a difference, it comforts me. And sometimes I might even take a note that's come in and put it on my desktop. And it's just a reminder to give me fortitude in those times that can be really difficult. So another thing that's a survival skill is humor. So I would say educators have, the good educators, they're really funny. And that's what's kept me into this work that I do, because they remind you sometimes of the absurd situations you get in when you're working with children. And, I'm reminded of this principal where he was, it was right around exam time, and he was near the window looking, and he saw this student leaving way before dismissal time, and his mother picked him up around the Rotary. And he calls up the mother as she's driving away, and he says, you realize dismissal time's in an hour and a half. I was just wanted to find out why your son is leaving us. And she said, oh, he has an orthodontist appointment. And the principal's thinking to himself, why is it that so many kids have orthodontist appointments right around exam period? But he's okay. She thinks she's hung up the phone, but she hasn't. And he overhears her saying, to her son, I'm sick and tired of covering for you. You've got to get to be more responsible. And it's just these moments, I think, that we have to be able to sort of step outside of ourselves and see how absurd some of the things that happen to us are. And I want to tell you just an anecdote that happened to me, and it was about, a phantom patient like I was telling you about before. It was, we'll call her Anna, and she had not been coming to school. She was getting more drug involved. She was hanging out with a really tough crowd. She was this just real dynamo, though. She had a bossy way, and she was undermining all the authority in the school, but she had this sort of piss and vinegar that's kind of teenager that I just love. And I decided to do a home visit, and I was sort of feeling pretty proud of myself. It's not often that child psychiatrists do home visits, but I wasn't getting her in the office, and I thought I was going to, do that outreach. And I show up at her house, and I'm sitting in their living room, and there's Anna, her mother, her father, a Parrot, and Nancy, me. And the father is going on and on about his chronic pain and his shoulders ache and he's been having a cough, he hasn't been sleeping well. And in my less than empathic moment, I turned to him and I said, "You're not dead yet." And there was sort of this silence. And then Anna was gone, the mother was gone, and the father was gone. And there was Nancy and the parrot, me and the parrot, in the room by ourselves. And life can be absurd. It can be more absurd than Monty Python sometimes. And so there's the parrot, and all of a sudden, the parrot starts to go dead, dead, dead. So I'm like, okay, let me just kind of leave and get out of there, go back to the safety of my office. And I'd like to say, that this, that things just went perfect, and she, Anna was so happy that I came to her house and that she started to come to meetings, but that didn't happen. She didn't come. She ended up getting a GED, but 10 years later, I was teaching adult residents, and one of the adult residents came to me and said, "I have a message from one of your patients. She heard that I knew you. Her name's Anna." And I'm like, "Anna? What?" She said, "She wants you to know that she's doing okay, and that she did go on to end up having a problem with addiction. But then she had a child, and she decided she wanted to turn her life around. She came back into treatment, and she wanted to make sure that you knew never to give up." That's the beauty of being a community psychiatrist. So the other thing I want to talk about is the creativity that's involved in the work we do. When we make therapeutic connections to our patients, it has this quality where there is when insight happens, there's a quality where it is a little bit of magic. There's all this sort of formulation that goes into it, which is so important, but it has this chemistry that keeps me in the game. And I want to tell you two stories that may reflect that. The first is, oops, I forgot to. The first is about a teenage kid who was psychotic and had been disorganized enough that he at one point had become suicidal and driven backwards into the Callahan Tunnel. Had had a couple hospitalizations. His mother had been adamant he didn't want him. She didn't want him on medication, and the parts about whether the workup about being psychotic had already happened. And my goal in that interview was to find out what made her so frightened of having her child on medication. And in the interview, one of the questions that you ask when you're collecting data, and I was sitting there with now this 36-year-old mother, and the son was, "Do you have a family history of suicide?" But my question ended up being something different. I asked her, "Have you ever known anybody to die by suicide?" And that was sort of an odd, maybe creative question. She got really defensive. She said, "Why did you ask me that?" And I felt a little bit like, okay, do I stay flexible? Do I sort of be transparent about my why I did that, if I can understand it myself? Or do I just switch topics? And something about my intuition said, stay with her and open up, take a risk. And I said to her, I'm not sure why I said that. But my mother died by suicide when I was 4 years old. I wrote a memoir. I was very public about it. I spoke a lot in different places. And I began to sort of develop a sixth sense of when people had been impacted by suicide. So I'm not sure what I meant by that question, but I'm wondering what it means to you. And her son was watching her like a hawk. She took a deep breath, and she told me this. She said to me, in this almost small voice, she said, "When I was 6 years old, there was this girl. She was 17. She was beautiful, and she'd broken up with her boyfriend. And she came to me. She lived in Central America at the time. She came to me in the streets right before dinner, And she asked me to go to the market and buy her some rat poisoning. And I could tell she was a little bit sad, and I thought, I'm going to go make her happy, and I went to go get her the rat poison. I didn't ask her why she wanted the rat poisoning. And I came back and I gave it to her, and I went to go eat dinner. And then I heard this wailing in the street. My mother and I, we went out, and we found the 17-year-old mother was wailing because her daughter had eaten the rat poisoning and had died. All of a sudden, I had enormous empathy for understanding what looked like a rational decision to give her son medication, why she was so fiercely opposed to it. And it shifted how I worked with her. The other thing that I want to share with you is another story that's about how creative we have to be when we're being stonewalled by a patient. And I want to share a 17-year-old who had actually had a heroin addiction. And she was one of those remote phantom patients that I was talking about. She wasn't showing up for treatment, and we were brainstorming about how to connect to her, because when she would talk about it, she would tend to be fairly defensive about her habit. And I was at a teen health center meeting, which is when a group of providers come together and brainstorm. And we came up with this idea of her writing a letter from the perspective of dope to herself, and then her writing a letter to dope. And I wanted to share with you with this to bring you into her world and to understand this creative process that I'm talking about. So she starts with, "To Mary, you know I love you and I treat you right. I am the only one that is there for you. No one else seems to care, and no one else makes you feel as good as I do. I make you forget about your problems, your past. I make it all go away. I know you love me too, and I know you always think about me. You say you never want to leave me, but I know you've tried in the past, and you know how bad it hurts. I'll hurt you if you try to leave me, and I'll find you when you least expect it and hurt you all over again. I might even kill you. These threats aren't empty. I've killed many people before. You are no different from others. I know you don't want this to happen. I know you don't want me to hurt you. You've always come back to me when things aren't going right, and I've made everything a lot better for you. Even though I hurt you and make you feel bad at times, I'm the only one that understands, and I'm always there for you. You don't have to find me. You just have to find me. You know where I am. I love you, Mary. Don't leave me." And then she wrote this second letter to Dope, which sounds like a breakup. "Dear Dope, I wish we would have never met. You have taken so much away from me, my life basically, and now I don't know how to get those things back. I love you so much it's hard to manage without you. It hurts when you're away, and when you're away, for a long time, you are always on my mind. I don't even care about myself anymore. I have put all that care into you because you make me feel good. You fill that emptiness inside me, and I don't know how I'm going to let you go. Love, Mary." I find with this kind of opening, it fuels us. You know, when a patient or a student risks being vulnerable, and we're there to scaffold them, when they allow you in, it builds a sense of a reminder of what an honor it is to be a clinician. And it's this creative process, it reminds me, you know, Dan Stern is a infant researcher who looks at, the mother-infant bond. And, it used to be that we thought that the mother was sort of solo and the baby was sort of solo and that they negotiate something. But we've come to appreciate that there's this exquisite attunement that happens between the mother and the baby. And it's similar, I think, when our work is opening a door, when we're building a narrative with a patient where they're able to look at the abyss and move forward. It has that aspect to it. And you could say in a very dry way, oh, well, that was sort of like motivational interviewing because you're asking the patient to take the other side. But it's the creativity about being resourceful about what you're going to access that is super important, that we hold on to when we hit those roadblocks, because it gives us a persistence and a resiliency. So I want to circle back, and we've been talking about our own resiliency and how we bring it in, but to talk about now to switch a little bit and have two of my patients share what made them resilient, because ultimately we're building our own resiliency so that we can be present with our patients and make the kind of connection that fosters their resiliency. And I want to talk about first the patient that I talked about, who was the boy who for 3 years intermittently thought about jumping off the balcony. And now he's 24, he's a registered nurse, I asked him, what helped you? Tell us, teach these folks that I'm going to be talking to today. And he said, honesty and transparency were very helpful to me. Having people that I was comfortable talking with made it easy for me to be transparent. I had a hard time accepting the existence of the internal and external problems I was facing. Most of the time, they were too ugly to look at, so I had to work hard to prevent reverting to the default of denial, which I knew at best was a short-term fix and a long-term problem. Talking to you and Dr. Kelly and experiencing your empathy, I was able to open up to you and eventually to myself about what was going on and what needed to be done. So this exposure, honesty, transparency bundle requires courage, which in my experience was facilitated by empathic, personable, and skilled professionals. He's a smart guy. Oops, I have to go back. The next thing next patient that I want to share is also in her mid-20s. She started seeing me in 9th grade. She'd been adopted. She'd been sexually abused not by her adopted parents at some point. She dropped out of college for a year, and now she's in one of the helping professions. And I asked her, what helped you? And she said, I think something that keeps me going personally is that I have high expectations for myself and a strong work ethic. Even when I'm feeling overwhelmed and stressed or in a depressed mood, I'm fundamentally a doer, and that always eventually takes over and keeps me going. I'm not sure if this is advice, just something I know about myself after seeing this pattern reemerge over the years. Another thing that I've learned is not to be afraid to reach out to others when in stressful, overwhelming situations. I used to think I would be a burden or exposing myself to being perceived as needy or bothersome, but I found out that I needed to get over my pride and just ask for help when I know I need it. This was a big one for me to accept. She goes on. Also, what has made me feel stronger over the years is just accruing experiences and situations that were challenging and overcoming them. Using thought processes very similar, if not identical, to traditional CBT, I can look back at my previous hardships and realize that what is in front of me is just another version of a previous challenge that I've overcome. This helps me to keep perspective and know I'm fully capable of facing challenges in life and working through them. One final thing that I've been doing on a weekly basis, if not more, is a thankful list. This is when I sit alone and state out loud all of the things that I'm thankful for. Big things, little things, funny things. It's a time for me to regroup and reaffirm what is meaningful and what makes me happy. It helps me to be more appreciative and positive. So, what patients have highlighted us, I swear I didn't share my talk with them before they did this. They highlight us, they bring us full circle about what we want to do to nurture ourselves so that we can be available to make the therapeutic connection. And one thing is to learn from our setbacks, not to catastrophize, not to magnify, and to have a strategy that we can access to help us when we have that detour so that we can get to insight and progress. The other thing is humor and being able to stay light and have a twinkle in our eye and be, that our patients are watching us and we need to mirror back to them a sense of this buoyed spirit, however we get there. And staying creative at those times when we see a barrier, being resourceful, and that comes from us both taking care of ourselves and allowing ourselves the kind of inspiration that will make the connections to our patients. And this leads to empathy. And empathy is a life-saving connection. And it's an honor for all of us to be doing this work. Thank you.